All right, let's jump right in. In the next few minutes, we're going to build a visual map of what happens when breathing goes wrong. And look, this isn't just about cramming facts for an exam. It's about really getting the why, that chain reaction inside the body that takes you from a simple cough all the way to critical respiratory failure.
Okay, so here's our game plan. We'll kick things off with the body's warning signs, then get to the heart of the problem, the breakdown in gas exchange. From there, we'll look at the 3 big ways lungs can fail. Think structural, restrictive, and obstructive. And finally, we'll see how they all lead to the same scary place, respiratory failure. Let's do this.
All right, first up, when breathing goes wrong. You know, the story of lung disease doesn't start in a textbook. Nope, it starts with a patient, with what they're feeling. So let's decode those first warning signs, the signals the body sends when something is seriously off.
So, what happens when just taking a breath feels like a fight? Well, that feeling, that struggle for air, it has a name: dyspnea. And believe me, it's way more than just being out of breath. It's this awful mismatch where your brain is screaming for oxygen, but your lungs just can't deliver. That feeling right there, it's one of the biggest clues we have that a patient is in real trouble. But dyspnea is just the beginning, right? The body has other ways of sounding the alarm. A cough, for instance. Is it new, or has it been hanging around for weeks? The sputum. Yeah, I know, gross, but important. Gives us clues about infection. Now, coughing up blood, hemoptysis, that is a huge red flag you can't ignore. And then there's cyanosis, that bluish tint to the skin. That's a late, really scary sign that oxygen levels are tanking. Every single one of these is a piece of the puzzle.
Okay, so we've got the symptoms, but why? What's the actual failure point? What's going on mechanically? Well, it all boils down to one thing: a crisis in the lung's #1 job, gas exchange.
And this slide just lays it out perfectly. You've got 2 fundamental ways this can go wrong. On one side, you have hypercapnia. Think of this as a ventilation problem. You just can't get that CO2 out, and your blood starts turning acidic. On the other side, there's hypoxemia. This is an oxygenation problem. You can't get the O2 in. Either way, it's a critical failure of that all-important gas exchange.
Let's trace the path for hypoxemia, step by step. I mean, to get oxygen from the air into your blood, 3 things have to go just right. Step 1, you got to get enough oxygen down into the alveoli, those tiny little air sacs. Step 2, that oxygen has to make the jump, diffusing across the membrane and into the blood. And step 3, you need blood actually flowing past to pick it up. Simple, right? But a failure at any one of those steps, and boom, you've got hypoxemia.
And the most common place for this whole system to break down? It's step 2, with something called a V/Q mismatch. V for ventilation, Q for perfusion. So normally the amount of air coming in perfectly matches the amount of blood flowing by. But what if an airway is blocked? Well, blood flows past, but there's no oxygen to pick up. We call that a shunt. Or what if a blood vessel is blocked? Air comes in, but there's no blood to give it to. That's dead space. See? Either way, it's a mismatch. The system fails, and you get hypoxemia.
Okay, let's switch gears. We're moving on to our first big category of problems: structural failures. So what happens when the issue isn't the air or the blood, but the actual container, the chest wall, the linings, when the whole structure is compromised?
In pneumothorax is the classic example here. So think about it. Your lungs stay inflated because of this negative pressure in the pleural space. It's kind of like a suction cup holding them open. But if something causes a rupture and air leaks into that space, poof, the suction is gone. And the lung, which is naturally elastic, just collapses on itself.
And just look at this X-ray. It shows you exactly what that looks like. That huge dark area, that's all air that has forced its way in, completely crushing that lung. And it gets worse. In what's called a tension pneumothorax, it becomes a one-way valve. Air gets in, but it can't get out. The pressure just builds and builds until it literally shoves the heart and trachea over to the other side. This is an absolute life-threatening emergency.
But it's not always air that gets in there. Sometimes it's fluid, and we call that a pleural effusion. And here's the really cool part. From a diagnostic standpoint, the type of fluid tells you the story. If it's watery, we call it transudate. That screams pressure problem, like in heart failure. If it's thick and protein-rich, that's exudate, which points to inflammation and leaky vessels. And if it's pus or blood, well, that points you straight to infection or trauma. The fluid itself is the clue.
All right, on to our next big category: restrictive diseases.
With these, the container is fine, but the lung tissue itself is the problem. It's lost its stretchiness. It's become stiff, non-compliant, which makes it incredibly hard to take a good, deep breath in.
A perfect example of this is atelectasis. Now, this isn't the whole lung collapsing. It's thousands of those tiny little alveoli just deflating. The classic scenario? Post-op. A patient is in pain, they're not taking deep breaths, a little mucus plug forms in a small airway. So what happens to the air trapped behind that plug? It gets absorbed into the blood, but since no new air is coming in, the alveoli just collapse.
And this visual right here is exactly why we tell post-op patients to cough and take deep breaths. It's not just to annoy them. Look on the left. You see the mucus plug blocking the main path, and the alveoli just collapses. But look at the right. A good deep breath forces air through these tiny backup channels. They're called the pores of Kohn. This bypasses the plug and literally pops those alveoli back open. It's so simple, but it's absolutely crucial for preventing pneumonia.
Okay, time for our third and final category, obstructive diseases. And here's the easiest way to remember this. If restrictive diseases are about trouble getting air in, obstructive diseases are all about trouble getting air out. The main problem is a blocked, narrowed airway.
And here we see the very beginning of an asthma attack. So, an allergen, maybe some pollen or dust, gets into the airway and finds a mast cell. The result, it's immediate. Those mast cells basically degranulate. They explode, releasing this flood of chemicals. And within minutes, bam, the airway muscles spasm and clamp down. The walls swell up with inflammation, and thick mucus starts pouring out. The airway is closing. But wait, it's not over. Not by a long shot. This is the really sneaky part of asthma. About 4 to 8 hours later, a second wave of inflammation hits. All those immune cells that got called in for backup during the first attack, the eosinophils, the neutrophils, they finally show up. And they just dump more damaging chemicals, causing even more swelling, more injury, and making that obstruction last so much longer.
So what's the end result? You're left with this triple threat. You've got muscle spasms, a swollen airway, and it's all clogged up with mucus. It acts like a one-way valve. A patient can use all their strength to force air in past that mess, but getting it back out, it's almost impossible. That's called air trapping, and it is exactly what makes obstructive diseases so dangerous.
Okay, let's pull it all together. We've looked at structural failures, restrictive failures, and obstructive failures, right? 3 totally different paths, 3 different reasons things go wrong. But they can all lead to the exact same critical destination. And this is it, the final common destination, acute respiratory failure. Now, this isn't a disease itself, it's a state. It's the point where the lungs just can't do their job anymore. And for your exams, you gotta know the numbers. It's all about the arterial blood gas. Your PaO2 is dangerously low, or your PaCO2 is dangerously high, and your pH is dropping. That's the definition.
So now you can see how all the dots connect. All those conditions we just walked through, they're all just different roads leading to the same place. A massive pneumothorax, widespread atelectasis, a severe asthma attack. They start out totally different, but they can all end right here, with the lungs just completely unable to keep that delicate balance of oxygen and CO2.
And that's really the key takeaway. When you understand the why behind each step, from that first feeling of dyspnea to the specific type of failure, all the way to that final gas exchange crisis, you can actually see the whole process in your head. And even more importantly, you can start to pinpoint exactly where and how we can step in to change the story.